bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, the McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, and the Holland Bloorview Children's Rehabilitation Hospital Foundation. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAFC's programs and activities. All right, hello everyone, and welcome to today's episode of CAFC Presents, and the first one of 2016. It's great to be back after a nice break over the holidays. My name is Doug Maynard. I'm the Associate Director at CAFC, the Canadian Association of Pediatric Health Centres. And today's webinar is titled Understanding Stigma to Improve the Lives and Families Affected by FASD. All right, so once again, it's my pleasure also to welcome back my co-host who often joins me on these webinars, Dr. Gail Andrew from the Glenrose Rehabilitation Hospital in Edmonton and co-chair of the Research and KT Committee for CINSR is joining us. Her expertise is always welcome when we have topics that are of interest to our rehab community. And for those of you who don't know CINSR or might not be as familiar with CINSR, CNCYR, that's the Canadian Network for Child and Youth Rehab, and that is the network of CAFC members that share an interest specifically in improving delivery of rehab services for children and youth and other topics associated with children with disabilities. It's also, I'd also want to acknowledge our colleagues at the Public Health Agency of Canada. It's always a pleasure working with those folks over there in the area of FASD. This is part 2 of a 3-part series that the Public Health Agency has been supporting with us, and it's always a pleasure to work with our colleagues Heather Cahy, Holly McKay, and the rest of the gang over at PHAC. So big thanks to Public Health Agency. And I did want to mention that this is, I did say it was the biggest webinar. I told our presenters it's the biggest webinar we've had this year, but it is also our first one. But we've got over 320 lines connected, and as many of you know, there's many more than one person at the end of each one of those lines. So I'm sure we'll have as many as 400 or 500 or 600 people out there in the audience. So it should be a great conversation today. So I'll certainly try and get on with the presentation as quickly as we can. Just going to introduce our presenters now. Dr. Emily Bell will be first up. Dr. Emily Bell got her PhD from the University of Alberta in 2007 and did a postdoctoral research in neuroethics. Until recently, she was the associate researcher at the Neuroethics Research Unit in Montreal, where her research focused on a number of things, but including examination of the ethical implications of stigma in fetal alcohol spectrum disorder. And much of her research in that area was conducted while she was a member of the Neuroethics Core of NeuroDevNet. Which is one of the Centers of Excellence in the NCE program. And Dr. Jocelyn Cook is also joining her, and Jocelyn has a PhD in reproductive physiology from the Medical University of South Carolina. Jocelyn has been working in the area of FASD for many years with the CAN-FASD network, and until recently, in 2014, joining the Society of Obstetricians and Gynecologists of Canada as its first scientific director. And she's also an adjunct professor in the Department of Obstetrics and Gynecology at the University of Ottawa. So it's my pleasure to move on with the presentation. It looks like we've got our simultaneous translation going, and so I'm going to hand the virtual podium over to Dr. Emily Bell. Over to you, Emily.
Great, thank you so much. So thanks, I'm really pleased to be here today. And to have been invited to speak on this topic and about some of the work that we had done looking at the stigma associated with fetal alcohol spectrum disorder. And this is, as Doug mentioned, work that I did as it was funded by NeuroDevNet, and while I was part of the Neuroethics Core of NeuroDevNet, and along with co-authors who are also part of that network. So, okay, so I mean, I think the general underlying interest in this webinar underlies the assumption that there's a good understanding that stigma is an important part of the lived experience of persons with fetal alcohol spectrum disorder. And so our interest in this topic is really to do what we started with was a really broad literature review a literature review to understand stigma, to understand stigma in related disorders, in mental health, in children's disorders, in neurodevelopmental disorders at large, and use our clinical co-authors to add some context to fill gaps in our knowledge, because there really is very little written explicitly about the lived experience of stigma of those with fetal alcohol spectrum disorder, although it's pretty clear there's a general impression that that is an important part of their life experience, and that also healthcare and education policies have to understand, the negative attitudes that underlie stigma, so that they can be certain to not reinforce inadvertently these kinds of negative attitudes. And so policies and practices need to take into account the stigma that may already exist. So what I'm going to do briefly is I'm going to just talk about stigma. Where it's been most discussed is in mental health, or most described, most elaborated models of stigma are in mental health. I'm going to present to you this descriptive model of stigma in FASD, and the three dominating themes of stigma that we heard about that were really drawn from our literature review. And I'm going to talk about how public health practices and policies really need to take into account stigma, and whether there are sort of early ways that we can think about the potential ethical implications of our public health practices and policies. So stigma, generally, I prefer this first definition, but stigma has been described, it can be described at times as having both negative and kind of positive forms. In a negative way, it often has an impact on the person. So this first definition, it's a gap between what society perceives as your role or place in society and the actual attributes and characteristics an individual possesses. Well, so that's, you can tell, a definition that's really centered around kind of othering people. And you can see that it also has a lot of social implications. So it's about how we interact with people and how they perceive us. The second kind of, or I guess the positive version of stigma, is associated with applying stigma to behaviors. Sorry, that's my phone ringing. So in this case, it's described as a social process by which we might shame people from engaging in reprehensible or unhealthy behaviors. So this version of stigma has maybe been used most often in the context of something like smoking, trying to deter people from smoking, and this denormalization that's occurring with smoking behavior. But you can tell that the line here is really thin, so there's a danger, even if you're using sort of stigma in a gently sort of targeted form around behavior, that it eventually starts to affect the person in a very negative way, and that's important to keep in mind. So what we know from the context of mental health work done in the area of stigma is that there's quite a well-elaborated model or framework by which stigma sort of occurs. So it involves the fact that individuals or the public hold negative beliefs or attitudes, often that are very erroneous, and that can lead to stereotyping, and that stereotyping of groups, that othering of persons, then leads to prejudice, which leads to feelings of uncomfortableness, emotional reactions such as anger or fear, and that those can then also lead to discrimination, either felt by the individual who's being stigmatized and or experienced by the individual that's being stigmatized. And then the impacts of stigma are, of course, important. So stigma can lead to structural and personal discrimination, difficulty obtaining housing, jobs, opportunities in general, or general isolation. It can undermine help seeking. It can negatively impact self-esteem, something that's been called self-stigma. And it can further fuel misbeliefs, those negative attitudes and beliefs that actually start the whole cycle. It can also discourage disclosure of symptoms, behaviors to health professionals, and that also is an important element or impact of stigma. So I think maybe the poll questions are ready, so I'm just going to go back to if I can go back to the first poll question here. I would love to hear from the audience, your reaction to this poll question. Do people affected by FASD get treated differently in a negative way than other children or families?
Yeah, so this is, for those of you who haven't done a poll with us, this is your chance to just go up and click make your choice on the screen by clicking one of the answer choices, and give everyone a few seconds to make that choice, and then we'll see what the audience thinks. All right, just another couple seconds to put in an answer. All right, we'll close that off, and we can see that 97%, not surprisingly, said yes, they do feel that children with FASD get treated differently in a negative way.
Right, so I think that's a perfect foil for the importance of this topic and understanding more about what particularly drives, what kinds of negative attitudes and beliefs drive those stigmatized reactions, and often, I guess, what are the misconceptions that are driving those reactions. So within mental health, we've been quite fortunate because there really is evidence from very large social surveys of the general population to inform our understanding specifically of those kinds of attitudes and beliefs that drive stigma. So for instance, these large social surveys that have been administered to American populations, North American populations, as well as sort of European populations, tell us that some of the beliefs about those individuals that have mental illness are that they are dangerous, that they are unpredictable, that they are personally responsible for their illness and for getting well or not well, that their illnesses are chronic and unrelenting, and in some cases that they need our support or that they need to be treated almost like children. And similarly, we know more about the reactions that people hold towards those with mental illness, including the fact that they seek increased social distance from those people, that they sort of see them as needing to be excluded from social situations, so they have a reluctance towards seeing them in intimate settings, such as part of their families or close family members. As well as some social avoidance. So the idea or unwillingness of individuals to see or interact with those with mental health issues, or to see those with mental health issues interact with vulnerable groups like children, for instance. So within mental health then, stigma reduction has become really a key public health goal, and actually what was once very much directed towards reducing stigma by talking a lot about the biological origins of psychiatric or mental illness has now moved much more towards targeted changes in the stigma that's experienced. So trying to change workplace attitudes towards those with mental illness, or employer attitudes towards those with mental illness, as well as to increase the personal connection that anyone feels with others with mental illness. So trying to increase that proximity or exposure that the general public has to understanding that many people that they interact with on a daily basis suffer from mental illness. So one of the things that struck us most when we were looking to do this work, as I say, we engaged in a very broad literature review to try to understand more about the stigma that is affecting those with FASD. And when we were looking for this literature, we found very little of the literature was really directly on the topic of stigma and FASD, which is why we had to go so much broader to try to extrapolate some of the key threads that move throughout similar literatures. And so in talking with our co-authors, we sort of thought a little bit about some of the gaps that exist in our understanding of stigma and FASD. And some of, I think, the important places where that lack of understanding comes from is the fact that obviously we lack this massive sort of set of public data about attitudes that exists in mental health. But we also have sort of a certain lack of qualitative studies of individuals with FASD, sort of these deep reflections that could pull on the experiences of those themselves to understand better what the experience of stigma is. And importantly, biological parents and children dyads also are often missing from research. And of course, those would be important groups to hear from in understanding better about stigma. So I want to present then to you what we saw to be the dominating themes of stigma that we noted in FASD that we were able to extrapolate from our literature review. Those themes were three. There were three themes. The first theme is a stigma attached to biological mothers, so a personal responsibility and blame placed on biological mothers who drink during pregnancy. The second theme is about felt and enacted stigma experienced by children and their families, and when I say families in that case, I mean biological, non-biological, adoptive families, and negative and anticipated life trajectories for individuals with FASD. So I'm going to unpack each of those a little bit more, just to give you a sense of, first of all, what the literature tells us, or how the literature helps us to understand the types of stigmatizing reactions that fall under each of these themes, how we can extrapolate, I guess, some of the negative underlying beliefs that underlie those, and also what misconceptions, I guess, shine through if we see these stigmatizing reactions or these negative beliefs. So the first theme is the theme of personal responsibility and blame towards biological mothers. So from our literature search, we see that mothers who consume alcohol when they're pregnant fear negative judgment by the public and often by healthcare workers as well. That mothers fear losing their children to protective services, and that certain jurisdictions have even tried to criminalize drinking during pregnancy. So there have been important cases over the last few years in the UK and also in Australia around this issue of criminalization and alcohol during pregnancy. So, of course, what these kinds of stigmatizing reactions we think reveal are the somewhat negative beliefs and, of course, erroneous, often negative beliefs that underlie are that biological mothers who drink are failures, that they are unfit to parent, and at the most extreme case, it's trying to give us the idea that people think that they might be criminals. Of course, there are misconceptions built into these negative beliefs or other things not taken into account. For instance, the many reasons that women drink without knowing they are pregnant at times, and that many factors impact the development of FASD, not alone drinking during pregnancy. So if we do the same exercise to understand the second theme of stigma around felt and enacted stigma experienced by children and their families, we see from the literature, and in this case particularly, we had to, again, because there were so few qualitative studies of the experience of children or families with FASD, we had to draw on a broader sense of a broader literature of qualitative studies looking at children with neurodevelopmental disorders and their families and the perceptions of others. But what we see is that children affected by FASD report difficulties making friends. They hold a perception of being different, and they go through generally a lived experience of marginalization. In the more general sense, children with neurodevelopmental disorders, their capacities are often underestimated. They feel like they're blamed for their learning challenges, and parents raising children with neurodevelopmental disorders often say that, especially in the education system, their child is viewed as naughty and, responsible for their own behavior, but just sort of acting out. So the negative underlying beliefs that are sort of insinuated by this are that the children are naughty and they're responsible for their bad behaviors, and also that children with neurodevelopmental disorders are meaningfully, in a negative way, different than their peers. Of course, this also reveals some, I guess, misconceptions or some elements that aren't taken into account that, should be part of the beliefs that we hold. That labels are tools often for accessing services, but of course people are not labels. And that children with FASD can be supported in different ways to succeed at school. So that's the second sort of theme around stigma that we saw in our literature review. And the third theme is around anticipated life trajectories for individuals with FASD. So again, looking at the literature, what we saw was that, I thought that this was actually quite an interesting quote, that public attitudes about criminality or an anticipated poor life trajectory for those with FASD are a combination of perceptions about the disorder itself and the reality of the individual's lives. So this is nuanced. However, there's some evidence to say that stakeholders interacting with adults can adopt a frame that shows them or characterizes them as deviant. So they're responsible for their own behavior, but they're unable to manage their behavior. And that's different than when they're seen as children as needing sort of support and assistance. So some of the underlying negative beliefs that I think are shown in this kind of stigma are that a belief that there's rampant criminality, drug use, alcohol use among those with FASD, that the multi-generational appearance of FASD is uncontrollable. What's not taken into account these are just a few examples, are that there's actually a high victimization of persons with FASD. So it's not all about their own negative life trajectories, but also the fact that they can often be victimized by others. And that structural social inequalities exist for those with FASD that frequently can also impact their opportunities that are available to them. So this model of stigma, I guess these three elements, or these three parts of the model, these three themes, for us, what they do is they interact, they link, they say that the stigma, it's tied up in, all three of these issues, and they're linked to multiple targets. So, biological mothers may be affected by stigma, but that also can influence their children and the families, even non-biological, that might adopt children. So these are very sort of, I think, pervasive and ingrained reactions that can impact and influence different stakeholders of different targets over time as well. So I think I have one more poll question. I'm not sure if we could do the poll question or I should just carry on.
No, we can do the poll question for sure.
Okay, great. So the poll question is this. I would just love to hear, I guess, quickly your feedback on whether seeing the model presented in this way with the, the literature summarized, the negative, I guess, misbeliefs or attitudes, as well as the misconceptions that are hidden underneath, help or impact your understanding of children and families affected by FASD, either positively, or this model has no impact on your understanding, or it affects, or it negatively, I guess, impacts your understanding of children and families.
All right, so one more time, just go up and make your selection on the screen. And while we are waiting for everyone to put in their answer, we did, after the previous question where we talked about how people perceive children and families with FASD, Lucinda put in a comment that she felt that at least the patients perceive this negativity and avoid seeking a diagnosis in many cases. So certainly a good comment there. So we'll just wait another couple of seconds to get some more responses. All right, there we go. You can see that 77% have said that they positively impacted their understanding of children, and only one person said negatively, so.
Okay, good. I hope that it actually, I hope that it contributes to, I guess, improving dialogue around this issue by narrowing, I guess, some of the discussion into these three themes, or maybe helping to frame the discussion a little bit better. And around that, so I think we're going to attach the link to this in the notes following, or on the website. But this is actually a PSA for FASD prevention from last year, from Alaska. And I would, really invite you to watch this. I personally find this a do not do kind of example. So when I watch this, I see every theme that I discussed coming through very loud and clear, without any of the nuance, without any of the potential misconceptions built in. So there's a very strong theme of sort of blame, even though a woman drank before she knew she was pregnant, in a very sort of casual social gathering, not a party or anything, which is then followed with, a father leaving her and her child, and the child going on to live on the streets. And so I personally, I think this is an impactful way of looking at some of the stigma that exists, because I think for me, the stigmatizing reactions really came through on this PSA. So in terms of like the last thing I guess I want to cover, which is about stigma and how we can understand stigma relative our public health practices, or especially prevention campaigns. And I think definitely stigma is one of the reasons that designing effective prevention campaigns for FASD is extremely difficult. And in a study they did many years ago which interviewed key stakeholders who had been involved in implementing different FASD awareness campaigns. The Public Health Agency picks up on this. Their report says one of the challenges was how to choose images and tone of the campaign to decrease stigma and blame, to show hope, to increase understanding of the role, of course, that partners, friends, families, and communities play. And so I think this is a constant struggle, this idea of how to well understand the impacts on stigma of any sort of FASD awareness campaign. And so I think the question becomes then, is there a way that we can routinely examine or be thoughtful about our practices and the stigma, and also just of generally the ethical consequences or the ethical pitfalls of potential programs. And there have been different, I think, frameworks discussed on this. I think this framework is one that I prefer, because I think it's quite easy, and if you go to the paper, they have a very detailed example that they walk through. This framework for thinking through the ethical aspects of a program was really developed around obesity, sort of awareness or reduction of obesity programs, because there's been a large feeling that those programs have also tended in the past to stigmatize persons who are obese, instead of hitting on some of the structural challenges that cause obesity or that prevent people from being able to lose weight. So the first step really suggested in this kind of a framework is to think on the potential ethical pitfalls in a range of areas, and they suggest a range of areas. So does the program, are there ways that we think that this program could affect physical health? Could it affect psychosocial well-being, equality, informed choice, social and cultural values, privacy? Does the program affect the attribution of responsibilities or liberty? So I'm just going to pull out of that an example, which is how does the program affect psychosocial well-being, to think through a little bit the kinds of questions that could be asked, or the kinds of exercise that could be done in thinking through FASD program, for instance, a prevention program for FASD or FASD awareness. Where step 2 is really to identify under what conditions the program is likely to have positive or negative consequences. So you can think this through as you're designing your program. The potential effects, for instance, on psychosocial well-being, if an FASD, for instance, awareness campaign focuses on a range of behaviors that promote healthy pregnancies, or the program presents the reasons why women drink in a nuanced way, this is likely to have positive psychosocial consequences. And you can think of the similar ways that a program would have likely negative psychosocial consequences. So if it creates fear in women who drink small amounts of alcohol before they know they're pregnant, if it presents people who drink during pregnancy as being irresponsible or with negative characteristic traits, then the program is more likely to have negative psychosocial consequences. So I think that's step 2. Step 3 is, I think, maybe the most important point, though. And step 3 basically says that once you've looked through the potentials, so you have a better sense of what kinds of messages could cause positive or negative consequences, well, then you're still going to have to decide whether or not those positive or negative consequences are justifiable, particularly, obviously, the negative consequences are justifiable or can be weighed against the potential positive consequences. And I think the important part of that step is really about assembling decision makers to weigh the significance and pitfalls, the significance and presence of ethical pitfalls. But within that, it's also, I think, about assembling important stakeholders in those programs. That means, assembling also those who would be affected by those programs to understand their perspectives on that balance between positive and negative messages. So I think I'll finish with that. The recommendations really from this, I think, fall on that front, which is first to gather more data about the experience of stakeholders, but also to include stakeholders more in both piloting and evaluating the effects of practices that are already in place, but also in doing some thoughtful reflection early on in program development about stigma and about positive and negative consequences or implications on stigma. And I guess, the lesson here is that it can be very useful to pilot and understand well, especially the negative attitudes and beliefs that drive stigmatizing reactions, because again, in mental health, a lot of this was very misdirected early on. So misdirected view that those negative attitudes and beliefs were about the non-biological nature of mental illness led to a lot of funding being directed towards trying to convince the public that mental health disorders were physical disorders, which they are, but that did little to change the public's reaction towards individuals who actually suffered from mental illness. So it's important, I think, to pilot and evaluate well our practices and policies. And I think that's where I'll leave it, and leave it open for discussion after Jocelyn's talk.
All right, thank you. And if anyone does have any questions before we go to Jocelyn, anything specific you'd like to ask, we can certainly take a couple of questions now while we're getting Dr. Cook ready to present. We did have a few comments coming in, certainly lots of agreement with much of what you said as far as the impact of stigma and why it's important to address, and certainly, as we saw from the poll question, lots of support for your model. We did have a couple of questions about the video as well. We did put a link to the video in the chat box, and we will also put that link on the Knowledge Exchange Network. And I took a look at it when Dr. Bell sent it off to me, and it really is a great example of, like she said, many of the things not to do. So it's a little bit long. It's 4 or 5 minutes, quite long for a PSA, but it's about 4 or 5 minutes long. So please do take a look following this webinar. All right, so it looks like we're ready to go. We'll now move on to Dr. Jocelyn Cook. Over to you, Jocelyn.
Thanks, Doug. I'm just trying to find my little slideshow thing here from beginning. Okay, thanks. Thanks, everybody, for being here today. So thanks, Emily, for that great presentation. So what I'm going to do is build a little bit on what Emily said and talk about using data related to screening and diagnosis for education and understanding that can have an impact on stigma through the way that individuals and families are presented and access programming and the ways that frontline workers interact with them. So I'm going to talk a little bit about the Universal FASD Data Form, which was a project that the Public Health Agency of Canada funded, and Dr. Sterling Claren was really the pioneer in this. What we did is we wanted to provide some real-time information on difficulties, challenges, and needs of those who present for an FASD diagnosis. We wanted to capture the type of diagnosis, recommendations for interventions, and some of the specifics around the diagnostic assessment and demographics, especially around brain function, and this is really important, or neurodevelopmental function. And these data, in this data set, really provide the first accurate spectrum of functional diagnoses and treatment plans across clinical practice in any country. And I just sent out the invitation to all diagnostic centers that I know about in Canada to participate in part 2 of this project, where we're going to be working together with NeuroDevNet to collect similar data from individuals who have an FASD diagnosis and be able to compare it to individuals with another neurodevelopmental diagnosis. And we're working again in partnership with CAFC for this, so that we can learn about different etiologies, how the behavioral phenotypes that may be common among children's neurodevelopmental disorders, and some of the treatment recommendations, all in the with the intent to improve outcomes for individuals and families. So this was a pilot project. We had 45 centers in Canada at the time, and we worked together to develop what kind of data that clinics thought that would be important to them in terms of reporting on their population and looking at demand for services and interventions, and then for the research team in terms of what can we start to answer about the patterns of neurodevelopmental dysfunction and better matching with interventions for affected individuals and families. So we collected anonymous information around demographics, the specific diagnoses. We have all the diagnostic information around the brain evaluations, other diagnoses, what kind of recommendations were made to children and to adults with an FASD-related diagnosis, and any kind of other secondary issues that may have come up were asked on the adult form. So I'm going to show you some of the results quickly. We have 307 forms. 289 of these had confirmed diagnoses. 218 children and 71 adults were included in the analyses. So the sample size is fair, not huge, but it's fair. 18 diagnoses were deferred for a number of reasons. So if you look at this pie chart, this is not surprising. So what this pie chart shows you is the proportion of individuals in that database who received the specific diagnoses under the FASD umbrella. So 6%, you can see, were deferred for later assessment. 79% received an alcohol-related neurodevelopmental deficit diagnosis. And if you recall, that diagnosis means that the individuals did not have the sentinel facial features associated with prenatal alcohol exposure, but their brain was sufficiently impaired neurodevelopmentally to meet the criteria for a diagnosis. So all that to say, these folks look normal, but they don't behave normally. And so that's really important when we think about stigma, because it really changes expectations when you see somebody who looks perfectly clinically in line with the general population, but their behavior can be so skewed because of the invisible brain damage that you see. And so that's really important to keep in mind. The other 13 plus 2% were individuals who did have some facial features associated with FASD. And so you can see that these are in line with the world data that show that most individuals with an FASD diagnosis look normally clinically with respect to diagnostic criteria. So this is what's really, really important, and this was what was really surprising to our team. So to get a diagnosis of FASD, you have to have 3 neurodevelopmental tests that show significant impairment, and we call those brain domains. And so 3 brain domains of impairment will get you an FASD-related diagnosis. And you can see here that almost 25% of the individuals in the database had 6 to 9 brain domains that were significantly impaired. That is a lot of neurodevelopmental deficit. That means that these individuals are very affected by prenatal alcohol exposure, and our diagnosis is actually very conservative in terms of that. So again, coupled with the fact that most of these individuals look like everybody else on the street in Canada, with the fact that they have such severe brain dysfunction, again, has a huge impact in terms of society as expectations for these individuals and how they're treated when when their behavior doesn't really meet the societal norm. Okay, let's see. Okay, so what we then did is look at these individuals and said, okay, among the percentage who have whose brains meet the impairment criteria for FASD, let's look at what some of their brain specificities are in terms of impairment and dysfunction. And you can see that most of the individuals, you can see the child patients on the left and the adult patients on the right, most of the individuals had some form of attention deficit or hyperactivity disorder. 63% of the children, 48% of the adults. And they also had some adaptive behavior and executive function deficits. And so you can see how these brain domains and these deficits, especially if they have 6 to 9 of them dysfunctional, would really translate into behavioral difficulties in society. And that's what we see with folks in terms of trouble with the law, trouble in the education system, trouble keeping jobs. So the question that we really started out with is there a common profile of functional deficit? So is there some pattern of brain domains, maybe 2 or 3 or 4 that group together that would be maybe predictive of prenatal alcohol exposure or FASD across those specific diagnoses, even like partial FAS or ARND? And the answer was no, not in this sample. Now, this sample may have not been large enough, and we may need to analyze some things by grouping diagnoses together, but right now, the data did not show that. What they did show, again, was that impairment was more significant than we had initially anticipated. And so I think that's really important. So as I said, that's where the data stand now. Our paper's just been published in the International Journal of FAS Research, and we're looking to expand the study and hoping to take what we've learned from this initial study, refine the data collection so that it's extremely meaningful for clinics to receive their data back, for families, and to be able to predict what kind of supports and services might be required for individuals affected by FASD and their families as well. So I guess the take-home message to relate back to the stigma situation is that individuals with FASD have significant brain damage. It can be very severe. They may look like normal citizens, but they cannot in any way function like normal citizens, and therefore the expectations around their behavior and function should not be at the same, or should not be the same as unaffected individuals. It's important that we educate people in society, I guess frontline workers who might be engaging with individuals with FASD so that they don't have unrealistic expectations. They don't have expectations that are not feasible, and that we can define success for different outcomes differently according to the individual's functionality and their neurobehavioral profile. And that's, again, where diagnosis comes into play, because the diagnostic assessment is very thorough. 10 brain domains are assessed very comprehensively, and a management plan and supports for individuals and families tailored to A, what communities have available, but B, in terms of the strengths and weaknesses that come out in the assessment are very important. And again, data show that early diagnosis can really lead to improved outcomes. So that was educating to the team. It was educating to clinics around around diagnosis and around functionality of individuals. Another important project that we did was to say, okay, so we know that these individuals are severely impaired in some situations, some more than others, and we all know that FASD and the effects of prenatal alcohol exposure are a continuum, but let's reach out to some sectors where FASD may be overrepresented, and let's help those sectors, the workers in their sectors, understand the implications of this brain impairment and how that may translate into the context of their interactions with individuals with FASD and also of women who may be at risk for having a child with FASD. So there was a big protocol released in the States called the Treatment Improvement Protocol, which is a really horrible name, but nonetheless we kept it, by the Substance Abuse and Mental Health Services Administration, and it's basically a document that shows and helps guide service providers to be able to work with individuals who have FASD more effectively, or with women who may be at risk for having a child affected by FASD. The U.S. tip was designed for service providers in the substance abuse and mental health fields and provides some screening and identification tools as well as a pathway for referral for diagnosis and services. Why would there be a need for a tip for FASD? Well, we know that there's high rates of mental health and alcohol and drug problems experienced by individuals with FASD. We know that FASD is likely overrepresented, but probably underidentified in community programs or agencies that provide substance abuse and mental health services. And again, there's other sectors that we know are also probably in the same situation, like justice, special education, maybe social work in some communities. We know that substance abuse and mental health settings do not currently screen for FASD intake in Canada, or for, well, I guess you would know if individuals were pregnant in the substance abuse situations. And opportunities to implement brief, effective approaches to improve outcomes for affected individuals are certainly available in these situations. If you're looking to identify individuals who, one, are at risk for having a child with FASD, there's a number of well-documented, well-researched, evidence-based screening tools like the TACE, the TWEAK, the CAGE, the CRAFT. These are examples. Again, they've been well documented in terms of data. Some work better with different age groups, some work better with pregnant women, to be honest. But the key is that individuals have to be trained to be able to administer these tests. They're short and sweet, but there's a certain relationship aspect to these. There's a certain interaction aspect of things and a certain methodology in terms of being able to accurately get good screening information to identify women that are at risk. We know that clinical judgment is really, really important. And when we talk to folks who are working in these environments that were participating in our project, they said, yeah, you know what, we sometimes suspect that these women are at risk for using alcohol during pregnancy, and we're not exactly sure what to do with it, what to do about it. And so we really wanted to help answer some of those questions and be able to provide some pathways to intervention wherever possible. So the second part was how do we actually identify when prenatal alcohol exposure may be a factor? How do we identify that these individuals may actually have FASD? Well, there's a number of screening tools that are available as well. And for all of this, CAFC actually worked with a public health agency a number of years ago to develop an online screening toolkit. And these screens are actually a part of that screening toolkit, except maybe the life history screen, which is relatively new. So the life history screen was developed by Therese Grant at the University of Washington, and it's a relatively new screening tool. And it's currently still being evaluated, but we thought it would be really important to look at this in terms of using this as a novel way to identify FASD. And it asks things like, do you have trouble in school? Is your teacher always telling you to sit in your seat? do you remember your mom or your parents drinking? So it's kind of getting at some of those risk factors in a more storytelling way, and it's usually used for a little bit of older kids up into adults. We also know for adults and for older youth, there's the Asante Parole Officer Screening Tool, which was developed by the Asante Center, and that is part of CAFC's toolkit. So what we did is we wanted to develop some training tools and modules for frontline workers in the substance abuse and mental health centers to be able to screen for potential alcohol use during pregnancy or potential FASD. And what we presented to them was kind of a potential pathway. And so one was, if you screen women who are coming in for treatment at the mental health or substance abuse centers, and they could be at risk for having a child with FASD, according to those screening tools, then you would refer them to some existing programs that they had, which were really mother mentoring programs or the parent-child assistant programs. If you suspect FASD, you would refer the individual for a diagnosis, and they would receive kind of a care plan by the integrated team. If they didn't end up having a diagnosis related to prenatal alcohol exposure, they would still receive a referral for assessment and appropriate interventions based on whatever their issues seem to be. So hopefully that makes sense. And they may, or like I said, they may have FASD, or they may not have FASD, but in any case, they'll receive a comprehensive assessment and get an integrated plan that will meet their neurodevelopmental needs. So that's kind of what we wanted to do. We wanted to say, okay, we think that FASD is overrepresented. We think that being able to represent this will help frontline workers understand FASD, the implications of FASD, and what it means in the work that they do and how they engage with these patients. We also want to get these individuals referred for an assessment, which may or may not happen. Okay, I hate these little kind of clicky things. Okay, so what we did is we recruited 3 large mental health substance abuse treatment programs in 2014 in Alberta. One was Venta in Calgary, Addiction Services in Edmonton, and the Métis Child and Family Services program from Edmonton. These were all linked to diagnostic centers. We provided a training program about FASD, the implications of FASD, what it means for treatment and programming and alternative programming, and also help them collect some data. So the workers were trained to recognize, and they were also given tools and training to screen for substance use in pregnancy and FASD. And they were given info, like I said, about the treatment and referral pathways. So it was really interesting because when we met with these folks, they said, you know, we often, like I think I might have already said this, we often suspect that FASD is an issue. We don't know that, but when we suspect it, we actually engage differently with this individual. We know that they're not trying to be problematic on purpose. We know that they probably have some challenges that influence their behavior, and they're basically not trying to be a pain. It's just the way that their behavior is coming across. And so we'll do things a little bit differently, they said. And we asked them to start documenting some of the things that they did differently. And they said, once we understand that prenatal alcohol exposure may be a problem, once we understand how it affects the behavior and the interactions of this individual in our work environment and our service delivery programs, it brings everybody's stress level down. And they said, you know, we don't get as upset when individuals don't conform. We come up with ways to try to help them be successful in our programs. They're not as frustrated with us. We're not as frustrated with them. And so they said the whole kind of approach and interaction really improves. And they said they don't need a diagnosis for that. A diagnosis is really important because you can learn about strengths and weaknesses and specificities for interventions, but it's not feasible in some situations. And they said just knowing that FASD may be a factor has us look differently at this person, set different expectations, set different goals, and we really improve our interactions and the outcomes for individuals and for the workers. And none of that had really been documented, and so what we're trying to do is start to identify some things that are modified in the programming and adapted that really are geared towards individuals with prenatal alcohol exposure, and that's kind of the next phase of what we're doing. But we do know that early identification of at-risk women is important to reduce the incidence of FASD. We know that prevention in this pregnancy often leads to prevention in future pregnancies, so it's not just a one-time prevention that you're doing. We know that the whole family can be positively affected by that. We identified potential cases of FASD that wouldn't have been diagnosed, and so these individuals got a diagnosis and an integrated care plan and some services. We know that screening now is feasible in some situations, but it's more difficult, we learned, to implement in complex programs like street outreach. For example, we had one program where, alcohol use during pregnancy from the harm reduction approach seemed to be better suited for these folks because they had such other factors that put them into crisis, that they had other issues that had to be really dealt with on an emergency basis first. And so that was really important as well in the clinical judgment of the outreach workers is important, as well as the tool used. So, like I said, the big thing about this was knowing that PAE, prenatal alcohol exposure, may be a factor, really changed the attitude, the interactions, and the behavior. And that was really important. And again, because of this, the impact or the impact and the feelings about stigma really changed in those environments toward the individuals who had potential FASD. So just to summarize a little bit in terms of where this work is going in the future, I did mention that we're restarting kind of data form 2, for which we hope to, we're refining the data collection system, basing it on some new evidence and papers that have been published, hoping to collect data that's meaningful to clinics and to provinces and to service providers and to programs, so that we can look at better matching the brain dysfunction with the interventions and the outcomes. We want to learn from other children's neurodevelopmental disorders, and are there similarities and differences and things we can learn from each other, and that's what we're working with NeuroDevNet CAFC on. We also want to learn about the individuals who come in for an FASD diagnosis but don't receive one. So what's different about their brains? What's different about their testing? What's different about the interventions that may work for them? And again, it's looking at the predictability in terms of neurodevelopment and prenatal alcohol exposure. So we're starting that project right away. We really want to expand the treatment improvement protocol for the TIP program for other jurisdictions. So as I suggested, we know that justice is important, and interested in education are two examples of where child welfare services, where people are interested. And the program is really basic education about FASD and how that translates into behavior and challenges and strengths, and how those can need to be thought about when you're developing programming or you're interacting with these individuals and their families. All in the major goal to improve outcomes and improve success in programs. And so we're looking at developing an online training program component to the TIP. We want to do a lot of training around talking to women about alcohol use, which has a huge factor about reducing stigma. We want to introduce a factor about talking to individuals about FASD and possible FASD, as well as becoming proficiently trained on the use of screening tools, because as I said, this is a sensitive topic and not everybody can just go out and administer these screening tools. And we would like to obviously partner with some other sectors as well, including some health professional education and training around alcohol use during pregnancy. So there are some implications for policy. We know that screening for FASD or at risk for FASD at any intake stage is important, and we know that many programs don't currently have questions related to this on their intake forms, and they also don't necessarily have the training to be able to recognize when prenatal alcohol exposure may be a factor, what does that look like, and what should be some of the red flags. We know that it's important to determine the prevalence of FASD in different sectors so that intervention programs can be better matched to the needs of these individuals. The scientist in me is really excited about this, but understanding the brain diagnoses and how that translates to behavior and to learning and to interactions and to participation in society are critical, really critical for improving the effectiveness of interventions, not just for the individuals and the families, but for the other folks who actually interact with these individuals and families. And again, this goes, understanding and education goes a long way toward reducing stigma. We know that training and education are key. We know that changes in program delivery might be really essential in a lot of situations to improve outcomes. If individuals with FASD can't remember because their brain is not functioning this way to remember to come to their sessions, then rather than get frustrated, some very small tweaks could be made in terms of reminders or some other ways to, put a meeting invite on somebody's phone, so, something simple, so that individuals can help to be reminded to come to their sessions, for example. So we know that education and training are really, really critical, and Emily talked a little bit about this too. And so at the Society of Obstetricians and Gynecologists of Canada, they've developed in collaboration with many partners, including the Public Health Agency, alcohol and pregnancy guidelines. Gail Andrew and I and others have worked to publish a few papers related to the general pediatrician's role in FASD diagnosis, the family physician's role in FASD diagnosis. We've done lots of talks to lots of different clinical departments to try to help them recognize the impact of alcohol use during pregnancy and help them understand how best to work with their patients and their families. And again, to educate, to reduce that stigma so that women and families are more comfortable talking about their experiences and asking for help and accessing resources. The Canada FASD Research Network's done a lot of work in this area, and we're just in the throes right now, final touches of developing an online education program geared toward diagnostic centers, diagnostic teams, and that should be launched hopefully later this winter. We're working again with the Public Health Agency to try to expand some of our standardized education and training related to both FASD and prenatal alcohol exposure, as well as alcohol use during pregnancy. And so I guess to sum up, I think that, I know this was a lot of data probably for some of you, but I think it nicely underscores some of Emily's discussion around stigma and how families are perceived, how individuals are perceived who have an FASD related issues, how women are perceived who may be consuming alcohol during pregnancy. And addictions is a whole other talk that we won't go into today because it's a bit out of scope. But I think that having data and evidence to support the fact that, one, individuals are often severely affected by prenatal alcohol exposure, even though they look like they aren't, is important. I think training individuals in society who interact on a regular basis, or any individuals really, but best to train those who interact with these folks, about the implications, not just alcohol use during pregnancy causes brain damage, but the so what piece. How does this look in your classroom as a teacher? How does this look as a child welfare worker? When should you start to think about the fact that this individual may have issues that are related to prenatal alcohol exposure. And then, so what do you do about it? And so I think we're taking that very seriously, and we're really trying to work together across national organizations, across sectors, and across the world, really, to be able to help answer some of those questions, help design accessible, easy programs to educate, to train, and to help folks understand the implications. All of that together should really help to reduce stigma, should help to improve efforts geared toward prevention. It should help to improve, hopefully, some of the impact of prenatal alcohol exposure and some of the outcomes. We have to do things differently, and we have to think about how to do things differently so that we're going to have something meaningful come out of it. And so I think having data to support that is really, really, really important, because governments and programs and all sorts of funders are now asking for, how do you know? Show me how you know this. And so that's part of why we're spending time trying to validate, in some situations, things that we know, like most individuals who have FASD don't have the facial features. And so, so I think that's really important. So I think by working together, we can really start to see changes in this field and measure those changes, which are going to help to fuel the story about why change is necessary. And it's a really nice kind of snowball effect that we're going to have. And I think there's a role to play for everybody. And I'm just really happy to be here and to be able to be a part of it, wearing a bunch of different hats. So thanks very much.
All right, thank you, Jocelyn. It was a great way to connect that need for data and the value of the data and helping understand and address stigma as well. So, excellent way to tie it all together. So, thank you very much. We did have a question from Leona that came in. I think you were talking about the universal FAS data form. It was right. You had the first tip slide up, but I think this question is referencing the research that the results that you were presenting from the data form study, and she was just asking what year the study was completed.
It was completed in 2013. We tried to keep going, but we ran out of funding.
All right. And we do have a couple of other questions, but I thought maybe we'd give Dr. Gail Andrew a chance to give her thoughts, coming from the rehab community and representing our CINSER network. Gail, do you have what's your thoughts on what you've heard from both Emily and Jocelyn?
Doug, I'd like to thank them both for this really, really important presentation, and I see it as a launch pad for future discussions. I think tying them both together, as Jocelyn just mentioned, the power of education and training and giving people the accurate knowledge to understand this disability of FASD, that's going to help reduce stigma. So I see that as a very important step one. But I see a step two, and once we have been able to diagnose individuals who are living with FASD, I think our step two is we need to make sure that they have equal access to the right support services and interventions to make a difference. And I think that's the next step in research, is what are the best interventions, and then evaluating them and using a longitudinal study approach so that we can follow individuals with FASD across their lifespan to see what is making a positive difference, and also identify things that are not supportive and maybe actually pulling them further into not being able to function and contribute to society. So I think that's going to be the exciting, what is the research evidence around interventions that make a positive difference? And the other comment I have is individuals living with FASD need to have supports by others, and we need to address the caregiver stress. How can we better support caregivers? And individuals with FASD, I'm predominantly a pediatrician, but my kids do grow up. And how can we best transition to adult services, and what should those services look like? And how can we advocate for them? So I think I see this as a launch pad for lots of future research.
All right, so we'll get on to some, thanks Gail, that's excellent comments. So we'll get to some of the questions here. The first one that came in was actually from Kelly, who was she's from a diagnostic clinic at Neo Kids, which is part of Health Sciences North in Sudbury, and she says she's not on your list, Jocelyn, of diagnostic clinics that participated in the Dataform project. She was just wondering how they can get on your list, how can they contribute FAS data. They assess children 18 and under, approximately 8 children per month. So, what opportunities might there be to contribute data to a collection process?
Perfect. That would be great. I did send something to Sudbury, and this is a bit out of scope, but I'm just going to give you my email address. But please, if people are going to email me about and yell at me for something, don't bother. No, I'm just joking. But my email address is jcook@sogc.com. So if you just send me an email, you didn't get a letter about the Dataform project about an hour ago, then let me know. We'll add you to the list. We would love everybody to be able to participate, and we're willing to help facilitate that. We're going to develop some virtual communities of practice, some quarterly teleconferences. So it's going to be kind of exciting. So if you could just send me an email if you're a clinic and want to participate, then we'll get you on our list. Thanks.
We'll put your contact information up on the Knowledge Exchange Network for anyone who does want to get in touch with you. We'll put that there as well.
Perfect. Thanks.
Yeah. This next question came in for Emily. She's saying that you mentioned, and I'm not sure that she heard you correctly, but she's saying that she heard you say prenatal alcohol exposure is not the only contributing factor to FASD. Could you sort of expand on that a bit?
Yeah, no, I may have sort of, spoke around what I was trying to say there. What I was trying to say is there are other factors than just alcohol exposure during pregnancy that contribute to the development of FASD.
Okay. All right. Dorothy's asking or commenting that one of the goals in FAS is FASD informed care, which requires education and training, understanding of complex case management and helpful strategies, and understanding risks and vulnerabilities. Are you familiar with that concept?
Jocelyn, I sure am.
Yeah.
And all of that's kind of a major goal in terms of all of the training that we do. I'm sure Gail is.
Yes, we certainly, when we are, after all of our assessments in our pediatric clinic at the Glenner's Rehabilitation Hospital and also our adult diagnostic clinic, we provide direct education to that child's classroom, individuals who are important in that child's life, so that they're FASD informed. This is another comment too, and I think this may be something that Emily is also alluding to. Many of our children who have been prenatally exposed to alcohol, their mothers have experienced a lot of stress during pregnancy, other factors, malnutrition. There's so many other factors that can affect the developing fetus. And from a human experience, it's difficult to tease out which is the most important factor. We have learned a lot from our animal research colleagues, where they can create within their animal labs and control for each variable. We cannot do this in the human condition, but we know that for many of our children, there's compounding one after another possible risk factors in the pregnancy and then after pregnancy, where there's a risk of trauma, and which is theoretically preventable, but in those early years of brain development, it's so critical to provide the optimal stimulation environment. Many of our children do not get that opportunity. So it's complex. The diagnostic process needs to consider all of those factors.
And that question, actually, or a comment, came from Dorothy Badry, who you might remember presented on the first episode in this three-part series, where they presented on their caregivers curriculum for caregivers working with individuals with FASD. So, and that presentation you can find on our Knowledge Exchange Network if you're looking for more information there. Julie has put in a comment, and we did hear a bit of this kind of comment even before our presenters did, and I shared some comments even before this presentation started, just based on the information we sent out. But her comment is, in a presentation about stigma, she's concerned about the use of the term substance abuse. The term labels the person rather than identifying the problem. And she's saying substance abuse supports a criminal approach to those who use drugs, while substance use disorder labels the problem and supports a medical approach. Any reaction to that? Maybe we'll start with Emily, and just from the perspective of, even with the information that we sent out about this topic, it's such a minefield of terms that we typically use in healthcare or social services to describe certain clinical things, but the inadvertent stigmatization that might cause of these individuals, inadvertently, but just it's such a minefield of terms that we commonly use that certain groups or individuals may find problematic. But any thoughts on that? Emily, we'll start with you.
Yeah, I mean, I would just sort of, I think, agree with you that, I mean, it is a difficult subject to discuss, because terminology and labels and themselves can, bring different nuances to the discussion. And I think this example is a really good one about the difference between sort of a language of substance abuse and substance use disorder. I'd be interested to hear Jocelyn's sort of view on that, because of the sort of treatment facilities that she dealt with, and what specifically their mandate is, and why maybe those terms are used over the other terms.
This is Jocelyn. I also 100% agree, and we should really be using the DSM criteria and language around substance use. To be honest, I don't really know why. I think we were modeling on the U.S. tip that was referring to substance abuse centers, and so we probably just used that same terminology, and we may not have even used it throughout in the training materials or anything. And so you're absolutely right, and I do apologize, and I will need to go through and change that on our slides for sure. We should always be using the correct, accepted terminology, and the kind that is not potentiating stigma.
It's Gail here. I have a comment about, I think this highlights the need to be very respectful in the work that we do within FASD. And I don't know whether people picked up, I purposely say individuals living with FASD, because they are individuals first. FASD happens to be the condition they have. And I learned that through my many opportunities of actually working with individuals living with FASD. They've become extremely important teachers to me. And it goes back to involving the key stakeholders, those individuals themselves, as we move forward in addressing support systems.
Yeah, this is Emily. I would sort of echo that idea, which is why I try, and I'd be interested if people have views that this is not successful, to also refer to, in order to also encapsulate sort of the experiences, not only of those individuals living with FASD, but also their families, to talk about those who are affected by FASD. But I'd be interested to know if others think that is good language or not good language.
Doug, if I may, it's Elaine. I'd just love to jump in for a minute and absolutely support what Emily and Gail have just said. And I think that Gail, I'll just say, participates among many others in our childhood complexity community of practice, for example. And that is the model that we are living by. And I think maybe that's one of the most important places to start. When you're looking at new interventions, when you're looking at training and education, it's the individual first, I think, that really has to be considered, and is not always the case.
We had a number of sort of comments supporting that. Danielle in particular is saying we do the same in special education. Students have or live with disabilities and are not disabled students. For example, a student with a learning disability versus a learning disabled student. So again, those subtle nuances cutting across many different sectors, finding that same issue around the language.
I think it also causes and has caused some barriers to potential collaborations and partnerships across sectors, and I think if we address that, and I'm going to say follow Gail's rule, I think we would get a lot further. I think we have come a long way. Don't misunderstand me, but I think that would be very helpful as a principle to collectively follow.
Yeah, we did have a comment from Joelle who's saying, she says, thanks for the presentations. She says, Dr. Cook brings an interesting way to attack the determinant of stigma, i.e. educating individuals and society. Is there any ongoing training for health professionals? And either, I'm not sure if perhaps within sort of undergraduate education programs, colleges and universities for nurses or social workers, counselors, etc. Are you aware of any ongoing training programs in this area addressing stigma?
This is Jocelyn. I am not. We tried for a while. We talked about the golden dream of getting FASD in the medical curriculum, and that was a whole nightmare. However, Emily or Gail, actually, being in the medical profession, might have some additional information on that. I think it's an important, we did talk about it being an important component of any kind of training program that we do develop that's geared toward, well, in my situation, toward health providers. We always talk about that and how we can incorporate some of this. But I don't know of any stigma-specific training. Does anybody else?
This is Emily. I don't know of any stigma-specific training, but I think one of the interesting things, like on this topic, that I pulled from your talk was that kind of training might be most, I guess, important or filtered or taken up by those who already have a proximity with individuals affected by FASD. So sort of having that combination of sort of proximity already, maybe they don't know that they have a proximity, but that proximity coupled with sort of a greater understanding that comes through training might be particularly sort of impactful.
And it's Gail, I'll just weigh in on that as well. It has been very difficult to get the topic of FASD within core curriculum in a variety of university programs. And I think maybe this is a call to university people who might be listening in, that this is such an important topic from its many aspects of both prevention-focused, diagnosis and assessment, and then supports and interventions, as well as general awareness as this is a public health policy. So I strongly feel that embedding, this topic of FASD with a core component of the curriculum being on making people aware of the stigma, because a lot of people don't even have the awareness that they actually do stigmatize. And I think it could be a very important topic.
All right. Yes. Deb put in a comment again talking about the language of sort of addressing the disorder versus the individual, etc. She says about 10 years ago, when her team started talking with colleagues about FASD-informed person-first language, her colleague / mentor Diane Malbin noted that she did not like the term, even the term FASD affected, though they thought it was better than the non-person language of FASD kid. So just lots of conversation about that topic. And Danielle is suggesting that even in public school programs, it's been difficult to include related learning outcomes, even in the public school. So Dorothy Badry again, one of our previous presenters, is commenting in Alberta. She says she teaches a bachelor's and master's in social work course on FASD and child welfare practice. Yes, they had 39 students last year, and they talk about stigma amongst many topics. And one assignment is to review the history of FASD. So there's one sort of example in the traditional education system where someone has incorporated FASD and stigma into the curriculum. All right. And if anyone else, again, this is a great opportunity when when this information is up on the Knowledge Exchange Network. If anyone has any other examples of these sorts of where it's been embedded in curriculum or other courses, or where it's been embedded in the education system, please do leave comments there and share that information with everyone. We are just about out of time. We only have a couple minutes left, so unless there's any last-minute questions that people are have their fingers flying on the keyboard right now, I think we'll probably close the questions off now, and maybe we'll hand it over to our presenters for any final comments, and then maybe we'll pass it after that over to Dr. Andrew to sort of close it off for us. So maybe we'll start in the order that we presented. We'll start with Dr. Emily Bell. Emily, any closing comments that you'd like to leave the audience with?
Sure. I think the first was brought sort of up by Jocelyn's talk, which was the idea that we actually still, I think, have a pretty poor, although there's been lots done in mental health, we still have actually a pretty poor understanding of how the idea of sort of visual signs of impairment or disability versus non-visual or signs of disability or impairment affect stigma. So I think we're still a little unsure about, visible signs versus invisible forms of disability. And then also about Gail's point about transition to adult services, I think, in particular, that is somewhere that we should look and focus some attention to think about the potential stigma that could be faced by individuals as they transition to adult healthcare services if they're not, familiar or they don't have a good understanding of the impairments that individuals face.
All right, thank you. And Dr. Jocelyn Cook, anything you would like to leave the audience with?
I think I'd just like to say that, I think we're all working toward a common goal. I think we have lots of passion in this field, lots of commitment. It's fascinating, ever-evolving, complex field. I think we all have a role to play, and we're all good at different things, and we're all trying to do the best that we can. And to me, the exciting thing is in Canada, we have such a unique culture around this that we're truly working together and partnering. And like I said, we all have something to contribute, and I just think that's really exciting. And I look forward to more contributions from everybody here, and I really appreciate the contributions that you all have made just during today's talk even. So I just want to say thanks.
All right, thank you. And before we go to Gail, we did have one last comment put in by David, who said in Victoria they had a women's diagnostic clinic, and 2 of their candidates were advised by their lawyers not to attend the clinic, as a diagnosis would likely mean they would not regain custody of their children. So just an example of where that stigma is really has a negative impact. So Gail, with that, anything you want to close this off for the audience with?
I think we're very lucky in Canada, as Jocelyn just said. We have the leadership of the Canada FASD Research Network, the work of NeuroDevNet, and the supports of the Public Health Agency of Canada that really set the foundation, but are also kind of fueling the engine as we move faster and faster forward to get the evidence-based research that we need to inform policy and make positive changes. So I think we're very fortunate. And
yes,
CAPC supports everything.
Well, thanks, Gail. And with that, I think we'll close. So thanks to our presenters. Excellent presentation. We had lots of comments, people thanking you for the excellent presentations that you gave. Very informative. As I mentioned, we do our webinars every Wednesday at 11 a.m. Eastern Time, and it's when you can watch live, you get to participate in these in the conversation, as we can see. But when you can't attend live, you can see the recordings, which we make available after the fact on the Knowledge Exchange Network. I would like to, and you will receive a message within a couple of days that will send you the link to that. So as Gail mentioned, thanks to the Public Health Agency for always keeping this topic at the forefront of our attention, and for partnering with organizations like CAPC and all of the other key stakeholders in the world of FASD. Without their support, we wouldn't be able to do these kinds of webinars and have these kinds of conversations. So thank you to our colleagues at the Public Health Agency of Canada. And also thank you to our translators. They did a great job hanging in there. There's a lot of complicated content for them to translate, so thank you very much to our translators for our French community up there. Next week, we will have a couple of great webinars coming up. Dr. Christine Weckerle from the Offord Center for Child Studies at McMaster University will be bringing us a topic that they're calling Picturing Wellness, Art, Innovations, and Knowledge Exchange for the CIHR Team Grant on Sexual Victimization in Boys and Men's Health. And Dr. Weckerle will be talking to us about an arts and case-based approach which combines the tradition of formal art analysis to systemically view complex visuals with emphasis on observed evidence. That sounds awfully complicated, but this is how they're using a traditional approach of viewing art pieces, like traditional art pieces of artwork, and applying that to cases of child abuse and child neglect to identify clinical signs that are often missed. So it's a really interesting topic. They have an art exhibit going on in Hamilton, and a conference is coming up, so there'll be more information about that coming up. So please don't hesitate to register for that one next week. And following that one, on January 27th, we'll be welcoming back Dr. Christine Chambers to talk about the hashtag It Doesn't Have to Hurt campaign. And that one's called It Doesn't Have to Hurt, Creating a Science Media Partnership. And joining Christine will be Erica M. Yes, that Erica M. from Much Music fame, for those of you who remember that back in the 90s. But Erica is now an award-winning online publisher of the Yummy Mummy Club, which is a blog, and it's an interesting initiative that aims to showcase strategies to close what is often a 17-year gap to translate evidence to clinical care. And this initiative aims to increase parent uptake and the application of evidence-based knowledge on children's pain through a partnership between health researchers and traditional and non-traditional publishers. This conversation will be about the area of children's pain, but also about how we might use these strategies to translate other evidence in children's healthcare. So many of you may be familiar with that one. It's had a lot of airtime on Twitter and other places, and getting a lot of attention. So it's really an excellent example of a really creative, forward-thinking knowledge translation strategy. So please don't hesitate to register for that one. So some great stuff coming up. Thanks again for joining us today. Thanks again to our presenters and to the Public Health Agency. And we hope to see everyone back here next week. Bye, everyone.